Yeah, I'm like, oh, I talk higher than I think I do,
That would be everything you got. Everything you got. You don't have to live with pain or chronic neuro issues any longer. In this podcast, you will learn how to stabilize your brain, body, and biochemistry for the rest of your life. I'm Dr. Teams, and this is the NeuroRESET podcast. Cool. All right, everybody, welcome to another episode of the NeuroRESET podcast. We have a wonderful guest with us. I will let her introduce all of her credentialing and the history and all that stuff, but we are really diving into the mind, trauma processing, and those kinds of things today with like a technique that I haven't really heard so much about, but sounds very, very powerful. So, Elizabeth, if you could finish introducing yourself, that would be fantastic.
Yes, thank you. So my name is Elizabeth Freese. I go by Beth. I'm a licensed professional counselor in Phoenix, Arizona. Two primary specialties. One is trauma. The second one is chronic pain. To help understand the trauma piece, what that usually looks like is childhood, developmental, kind of chronic traumatization over a period of time. Typically the people that I'm seeing typically have more than just like one event that has happened, right? So, you and I, before we got started, we're talking about attachment. So usually it's stuff related to early development, stuff with caregivers or parents or any social pieces. And then for the chronic pain piece, that looks, gosh, there's a range of that. It can be anywhere from different accidents, car accidents, motorcycle, or it can be things that maybe we were born with or different chronic illnesses. I work a lot with kind of women's health stuff, endometriosis, interstitial cystitis, PCOS, as well as different GI stuff like IBS, IBD, Crohn's colitis. Yeah.
So, sorry if I'm interrupting.
Yeah,
the
yeah.
interstitial cystitis, I've seen a few people like that in the career, and that's pretty typical. That's pretty difficult to work with. What's your approach on that? And we can talk about all the other things.
Yes,
right?
yes. Well, and I don't know that I'm specifically targeting that when I'm working with the women that have it. I'm working with their whole nervous system. Right. And so the pain that's running in their nervous system and the unresolved life experiences that they're working with.
And it tends to just kind of localize in that region for them, right?
Seems to,
Because, as we're talking about it, and you can describe like your training on it, but pain on one hand is just kind of a signal, right? Like there's localized tissue pain, there's unseen tissue disturbances that may or may not create pain, and then there's like a level of suffering, right? And suffering is different than maybe like an acute injury, right? So that becomes more neurological. I'd really love to hear your thoughts on that stuff too.
Yeah, so I'd say like when working with chronic pain and then also teaching them about chronic pain, we're working with the nervous system and an overactive nervous system. Someone that has kind of chronic sensitization or, oversensitization over a period of time. So their fight or flight system, which people are really familiar with, has been on for a really long time. Sympathetic dominance, as you know. So teaching them, how do we start to calm that down and activate the PNS, the parasympathetic nervous system, so we can kind of shift gears a little bit to start to cool things off. So then we can also start to work with processing maybe some unresolved life experiences that are still running kind of as if they're still happening, which is still activating that sympathetic state, right?
So let's see, how am I going to ask this question? When you deal with that like chronic, oh gosh, I've been having conversation with some people over the last handful of months, like talking about normalization of like traumatic things in their life or stressors. What kind of effect does that have? And have you like seeing that? You're like, oh, my husband's always yelling at me, or just in general, like, and you normalize like, oh, it's just him. But like it obviously has an effect on the system.
Yes.
Whether it's work related, whether it's just the way you feel, and everything, you become like normalized to it. You become numb to it in a way, right? What is an approach to help changing that understanding of like, hey, that's not normal? Do you know what I mean?
Yes, I do. Well, I think first it comes with education, right? Is teaching them, like giving the people that we're working with the language for like, hey, I'm thinking, a lot of the people that I work with have come from, home environments where maybe mom, dad, or whoever, or even siblings sometimes were yelling a lot or had really, intense behavior or were narcissistic or manipulative or whatever it was. And that is their norm, right? And so they end up starting to date things like that or being around people, things like that. And again, like that ends up being kind of the typical attachment that they're engaged with. And they don't even recognize, or maybe they do, but we'll just, for this conversation, we'll say that they don't even recognize that there's an alternative or there's something quote unquote wrong with that, are like just not healthy,
Yeah.
right? So giving them the language so they can understand like, hey, I'm actually coming from maybe not such a kind environment, or an environment that required me to be really hyper vigilant and really kind of alert all the time. You know, a lot of people relate to the saying of like walking on eggshells. Like we don't have to live like that. But oftentimes that's really familiar to us. So giving them the language, they can kind of speak to that.
So is it fair to say that people tend to like follow and look for all that comfort, like not comfort food, but like, hey,
Yes.
somebody yells, that guy's attractive to me, or that lady is like, she's super passive. Like, let's say my mom stayed at home
Yeah.
and she raised the kids,
Yeah.
but dad say based on XYZ was the way it went.
Yeah.
So then how does that affect who a male or a female looks for like later in life, you know? And you see that cycle just over and over and over with people. Like we see it, that they might, you know, they're in the box. It's hard to see it when you're in the box, right?
It's so hard when you're close to it.
It's easier to see it when you're outside the box.
Yes.
So interesting. Okay. So do you have anything to expand on that, those questions that I was asking?
Yeah,
Go for it.
I think that, you know, I can't say that we all end up following suit in that way, but I think it's really common. It really just ends up being like likes like. Like we kind of flock towards what's familiar, and this is happening so subconsciously that we don't have conscious awareness of like, oh, dad yelled, so I'm going to choose a partner that yells at me. It's that like I don't even really hear it, or my alarm systems are not going off that like, hey, this isn't okay, or this doesn't fit for me anymore. And then oftentimes we start doing maybe like, so like, let's assume that person's in therapy. We start doing the work and start to process and start to, you know, kind of clear out some of that stuff and untangle what they've been through. Then they can start to actually be like, oh, hey, this doesn't work for me anymore. I can see that was actually like abusive or aggressive or whatever it is. And I don't want to continue living in an environment like that.
So education and then decision making, really. Yeah. Choices.
Yeah.
Okay, cool. So So tell these guys a little more about maybe some of the process of what you do, like what it looks like. Why would someone come to you? Give me like some examples of maybe some cases that you've been working with over the last few months.
Yeah, so I think similar to you, like I often work with individuals that have tried kind of everything or feel like, you know, tried many things. And so oftentimes people are seeing me either as a last resort, or they're referred by, you know, their physician or whoever of like, hey, we've tried these Western approaches, these things aren't working, or they're getting better, but they're not meeting all of their goals or getting to where they want to be. So oftentimes people start working with me because they've lost hope, right? And they don't know where to turn. So what we start to do is, one, I start kind of case conceptualizing. I get a whole history from them, just like you do, right? Of like, hey, these are the things that have been going on. This is what's going on now. These are their goals. This is where we want to go. I can start to learn, what do they need? What kind of education do they need? What kind of skill sets do they need? What kind of coping strategies? What's going to help them function on a day-to-day? You and I, outside of this, have talked a lot about how do we get them functioning in daily living, so then they can start to do that deeper work. If we're not functioning in daily living, we can't really get into that deeper work because that's going to really destabilize us, and we're already feeling pretty unstable.
Yeah,
so
like a house of cards, like let's dive into the deep stuff. It's like we need to stabilize that house of cards, and then we can do the icing on the cake.
Yep.
Cool.
So we want to widen their capacity to navigate whatever's going on in daily living. And then that gives us, and that can look like anything. It can look like communication skills, boundaries, healthy patterns and habits, getting outside, walking, exercise, food. And then that'll, you know, getting a good foundation for that. And then we can start to look at as we're doing that, we're starting to look at the nervous system. Do they, what is going to be really helpful for them? Is it going to be breathing strategies, mindfulness, meditation? Is it going to be trauma processing? That's usually what I'm leaning into as in my profession, is doing trauma processing. And what that looks like is finding these different things that we've been through that are essentially kind of locked and stuck in. I mentioned this earlier, kind of stuck in trauma time. The brain keeps playing it as if it's happening. And the challenge with that is then the whole body, the mind, brain, and body is experiencing it as if it's already happening. So we want to process this stuff to bring it into adaptation. We want it to know, like, it's historical, we can't change it, but it's not happening now. So I use things like, historically I've used things like EMDR. Many people are very familiar with that. Of course, like CBT, DBT, kind of some basic skill building, but I lean more into bottom up approaches. So the one that I'm using now that I've been getting trained in over the last couple of years is called Deep Brain Reorienting. It's newer. It's coming out of Scotland. And what I think sets it apart from other trauma processing therapies that we have is it specifically targets the brainstem, but specifically clearing shock from the brainstem. And so when we go through anything physical, right, we have that kind of shock that happens to us. Well, that happens to us emotionally as well. And so what Frank Corrigan, the developer of DBR, has identified is that we've got shock locked in the brainstem, and he tracked the whole physiological sequence that we go through when we go through adversity. And in processing, I'm super simplifying this, but in processing, we slow down that physiological sequence and allow it to process through and kind of out of the system, which then brings it into adaptation. In DBR, what we call that is it's clearing shock, it's clearing affect, rage, grief, sadness, anxiety, panic, all of those things, moving through that, which leads to changes in perspective, changes in thinking, changes in feeling. Maybe we logically know that the event is over, so to speak, but we don't like innately and intrinsically know that. Now we do, which is pretty cool.
Yeah, for sure. So what are give some examples of maybe some cases you've worked through with like general complaints, and then, the intensity of it. And maybe some cases, like we know, are really, really deep and complex, and they might take longer. Other ones might, be relatively short. And I say short, anything with dealing with trauma or emotional, somebody had bad luck, right?
Yeah.
And, what's a pretty typical timeline for you to watch people go through the process and heal, assuming they're doing all the things that we're asking?
Gosh, sometimes I'm working with people for, 6 months, and sometimes I'm working with them for years. So it's person dependent, and then it's what they've been through dependent. I have some people, even some of the ones that I worked on for years, I can split the difference on that. Some we're still doing like the work that they kind of come in with, and it's just deeper stuff. They've been through like just hell and high water. So it's going to take a lot longer to get through. And then some are like, hey, I've made progress and I want to continue to working on different things. So it's going to, to be able to answer that I'm going to need to kind of know who is in front of me, but there are options for kind of all of the above. Is, shorter term treatment, longer term treatment. When we're working with trauma, like it didn't happen overnight, so it's going to take a little bit longer to kind of work with. One of my favorite cases to talk about is a client who suffered from, kind of like I was mentioning earlier, is women's health issues, right? So endometriosis, PCOS, interstitial cystitis. She's got a lot of different spine stuff. She has just kind of a plethora of diagnoses. She has been through multiple surgeries, especially for the endometriosis, surgeries, acupuncture, PT, all kinds of different things. And she's in some areas gotten, improvement and pain relief. And then some she's like, no, I'm still suffering. Like, this isn't getting any better. I've been working with her for several years, and we did a lot of great work prior to having the DBR, but what's been really great about having the DBR is since I've been doing that with her, she has just mentioned, like, I feel like I'm kind of back to myself, or even like I feel like a different person. I'm also able to handle the pain that I'm going through to a greater degree. It's still happening. I'm still in immense pain from like day to day or whatever it is that she's going through, but she can actually like navigate it. And that kind of speaks to what we were mentioning earlier, right? Is we need to widen their window and increase their capacity to navigate these things so they stand a chance at tolerating it.
So in regards to, let's say, pain, whether there is a problem there or not, let's kind of
structurally?
Yeah, like structurally, like, hey, we run all the images. We're not really seeing much, right? There's really no reason why you should be in pain. And then that individual goes on, they're just in pain all the time, let's say a few years. What impact does it have if they constantly pay attention to the pain and talk about it?
And these are I work with a lot of these people.
And like, what mechanism is going on that makes them talk about it all the time?
So,
loaded question. I know.
Loaded question.
But how many people out there are dealing with chronic pain and they're like, well, it's like not bad enough. You shouldn't be in this amount of pain.
Yeah.
So what are the things that we really got to like layer or look at to consider to reduce the chronic pain?
Yeah. So the first thing that I start to look at, so let's see if we can kind of break up that question. The first thing that I start to look at is the life events kind of that I've been talking about, right? Like the life events that they've been through that have gone unprocessed. If we've done talk therapy, it's maybe helped a smidge, but it's not getting to that deeper level. Like we need to do specific bottom-up trauma processing therapy to start to clear that. So oftentimes with the individuals that have clear scans, cleared MRI, all those things, they have like quite a bit of unresolved life experiences. It could be childhood, adolescence, it could be young adulthood, it could be adulthood. Usually there's a range, but we need to look at those things. So we need to start processing those things, which is going to decrease, or, hopefully in theory, decrease the somaticization of the events that they've had, right? That is increasing the TMJ or the jaw pain, or, the stomach pains, different GI issues, chronic migraines, headaches, back stuff. All the events that we go through in life, we experience them emotionally, physiologically, physically, like our whole body goes through it just as we do, right? So to not look at those things does a disservice when we're working on trying to find pain relief.
Yeah.
Okay, so that was part one of the question.
Right.
Part two of the question was?
I think really more layers
Yes.
on, what does the talking about it
Thank
do?
you.
Yeah.
Well, I think a few things. One, I think that we just get in pattern and habit and repetition. We don't even hear ourselves. So we would start with even some CBT stuff of like metacognition, thinking about what we're thinking about. Half the time, we're all kind of on autopilot, not even recognizing that we're saying, like, oh my God, my back hurts, my back hurts, my back hurts. Because my back has hurt for so long that I don't even hear myself saying anymore.
So it's a habit.
It's a habit.
So on one hand, you're like trying to break habits.
Yes.
But the problem, and I'll be the patient,
yes.
but the problem's still there.
Yes.
But I'm still hurting all the time.
Yes. So we want to
But
work.
there's no reason why that should be there.
Right.
Okay. So.
And we want to be careful on our language with that, because we don't want, so many people have had the experience of being like, well, it's in your head. We don't want them to get that messaging either. So it's like, okay, well, structurally, or, in imaging, we're not finding anything but we know that you're in pain. So something is going on. So let's look at a variety of different kind of categories that we can to start to tease this out and bring down the, decrease the sympathetic dominance, right? So if we're going to work with the thoughts and working with the mind, that's going to promote decreased arousal in the nervous system, because, okay, maybe I am waking up and I still have back pain, but if the first thing that I do when I wake up is scale my back pain, like that's the first thing my brain is orienting on. So instantly that's going to set arousal, because if I'm like, oh my God, I'm at a 7 or a 9 or whatever, now I'm panicking or I'm feeling anxious or fearful, or, so we want to work with, okay, I'm waking up, I notice that my back hurts, but I'm going to go out in the living room and stretch. And we just want to like divert and create some new neural pathways of, I'm going to start to think this way. It's going to take some time. So part of it is habit. Depending on the person, another piece is going to be identity. And not in a way that's like, I need this and like whatever, but it's like, I've had this pain for so long. Like, who am I without this pain,
it's a part
right?
of me.
It's a part of me.
Well, and it's like a double, I guess, two sides of the coin of, this is who I am.
Yeah.
And then the potential inability to visualize themselves without it,
Yes.
We see it all the time.
All the time.
All the time.
So how do we develop our sense of self to be a person with pain, but not to only be a person, like be pain?
Not be a pain person,
Yeah.
right?
Yeah.
A person with pain versus pain person,
Yeah.
right?
And we end up getting, just kind of like patientized, if we will.
Yeah.
I don't think that's a word, but
Right.
Like we start,
Well, like
we
think
hold
about
our
it, yeah.
diagnoses, and then like, that's who I am.
Yeah.
It's like, no, that's something I'm struggling with.
And it certainly happens in a lot of that functional medicine, like infection world, like Lyme disease is massive. So I know that when people start going to like Lyme literate doctors and mold specialists and things like that, they I think by accident get put into this box. And it's like, this is so important that you deal with it, that you can't, like, everything has to do with this, right? And it becomes like that lifestyle, and then becomes your life. And it's like, it breaks my heart when people come in and they're like, oh, when you're a Lyme patient, I'm like, whoa. Like, you're not a Lyme person. Like, you may be dealing with it, but you can get rid of it, right? I'm not the guy to do that, but we can refer you to someone. Mold, or, oh, I'm a headache, or my neck pain. Like, when they start calling it my XYZ, I know we have a bigger problem going on.
Yes.
And that is tough. So like, let's talk about just pain for a second. What would be some really simple tricks, and we'll call them tricks, almost like distractions that we can start to utilize? And maybe, let's say someone's listening and they're like, my husband's always talking about pain. Right? Like, let's say they have a reason to talk about it, but talking about it isn't making it any better. Right? So what could we say that person might be able to suggest to maybe try to change a little bit of that pattern? Simple stuff. Not like, this isn't like this replaces coming to you. This is like, what are the things that you see across the board that are beneficial?
Well, one of my favorite skills to recommend is going to be biofeedback. And so, we know people with pain have a low heart rate variability. So different breathing exercises or different biofeedback techniques that help that. There are really great resources online, like on Gaia, which I think is like a TV app.
Yeah.
The HeartMath Institute, they have HeartMath, which is a type of biofeedback. And so there's a program literally on our TVs that we can access and just start to use some different techniques that are going to increase our heart rate variability, which is going to decrease our pain. So I always like to go to different breathing exercises because I think that's one of the fastest ways to start to regulate the nervous system and decrease our pain.
Cool.
And I say that because like when we're in pain, as you know, like like we've talked about already, right, is the nervous system so like sensitized and overactive, we need to start to cool that off. The fastest way to do that is by taking some deep breaths and focus breathing.
Yeah. So for all you guys that don't do your breathing
Exercises.
Yeah.
Yep.
Nailed it. Thank you for saying that.
Yes. Well, it's so important.
Right, Ree? We need, some people need to breathe a little bit more.
It's so important. And and I think we're all learning and we recognize how important it is. Some people, we're like, it's just breathing. It's breathing.
Yeah. Well, when you're in a sympathetic mode, what kind of breathing do you actually have?
Yes.
You're like hyperventilating all the time, right?
Yep.
So, and so one thing on the breathing that we talk about in the office is trying to, like, certainly when it's normalized and it's just kind of a habit, I ask people to look at, like, let's say, list the number of stressors, like it's this person, this thing, this job, the dog bark, whatever, the startled response. Like, okay, let's say we got 5 things, and I need you to become aware of what they are. And so what I ask people to do is, out of a scale of 10, tell me what intensity that stressor has to you. Some people are like, that's a 25. That's a 9. That's a 6. All right, cool. Let's add that number up. You're like at a 40 out of what should be a 10 or a 20. So we talk about, like, when we talk about breathing being that thing that's going to ultimately be the easiest way to calm people down. And depending on the intensity of that trigger, how much you breathe matters.
Yeah.
So like 3 to 5 breaths when you're in the middle of a 25 out of 10 is probably not going to make any difference whatsoever.
No.
It's going to be better than not doing it at all.
Yes.
We know that,
Yes.
but they don't feel it. Right. And so that's something we definitely have that conversation with our patients to help them understand, like, hey, you got to do this. This is almost the number one thing you have to do. Sometimes we don't start people for over a month and they just do breathing and they just do passive therapies, like laser, PEMF, vagal nerve stimulation. We check in with them and start to discuss a little bit, like, hey, what was your stressors like? Like, is it the same one? How are you looking at that? Are you waking up and starting to wonder, am I going to be in bed all day? Like, if that's the first thing, like, you know what? It's going to fire all those chemical regulators. It's going to fire all the neurological structures to make you stay in bed. Right. And so it's having that conversation from someone that does this for a living is really nice, because all of you guys are going to be listening.
Well, and what's really important about that too is to do it before we're in panic.
Yeah.
So our brain knows how to access it and what to do with it, right? So before I'm at 25, when I'm just like, whatever my like lower number of that is, that's when I want to start to implement that. So that way because otherwise when I'm panicking, like, this is offline.
Yeah.
So it's going to be really hard to grab a tool I've never used. Yes.
Yeah.
Yeah.
So you're saying that when you're having a good day, you almost want to double down on this whole breathing aspect.
That's a great day to do it. That is a good day. Is a great day to start to implement this stuff. And that's, I think, our, like, maybe one of our challenges as humans is we start to feel good and we stop doing the things that got us there.
Yeah, it drives me nuts.
It's so challenging.
I do the same stuff.
Me too, yeah.
Right? So it's like human nature to, if nothing's bothering me, I'm not going to be in, I have to take care of this mode. It's like, I want to be in living and thrive mode, which is what we ultimately want to see, right? As practitioners, we want you to thrive. We don't want you to try to survive all the time. But sometimes you got to do it till you come out on the other side. And yeah, it really is an interesting dynamic and I mean, we see it all the time, because our patients are a lot of POTS and dysautonomia, the migrainous stuff, the dizzy stuff, and all of that is a direct relation to the function of the nervous system. So that when they have a good day, they go and use up all their energy for tomorrow, and then they crash. And it's like, hey, we warned you about this. Like,
it's so common.
I'm even using the 50% rule at this point. Instead of, it used to be 80%, which works for most people, above like a certain percentage, say like their functional level, even though it's arbitrary, they might put it around 50, 60%. With folks like that, we use 80% rule all the time. Now, when we're having people come in at their functional level of anywhere between 5 and 30, like we're 50% at most.
Yeah.
And a lot of people, because they've been in that, I don't have any energy today, so it's a 0. And then other days they're like, I feel good today, so they go 110.
Yes.
And it's like there's that high-low is
Yep.
really difficult for people to figure out how to navigate.
Yep.
Well, I don't feel anything with this workout. Hey, that's perfect, because you're not going to feel it tomorrow. Like if you go and do this big workout today, it's going to crush you tomorrow.
Yeah.
So you can't keep living this yo-yo life, even though it feels good in the moment. That's like kind of that dopamine fix.
Yes.
So we got to fix the dopamine by just being consistent, right? And
Yeah. Yeah, that shows up a lot in my office too. I think a lot of us as clinicians really experience that. However, we're kind of treating it as like, if I can't do anything, then I have to do the most the next day. And so something that we work on a lot is the messaging of that, and like kind of reworking our stream of consciousness rather, or our train of thought on like, no, just because you feel good today does not mean you have to do the most. Do 50%, because like let's build up let's widen your tolerance for it, so that way you don't crash tomorrow. The challenge with that is oftentimes shame and guilt step in, right? Or fear or anxiety.
sure.
Like, well, I'm feeling good today, so I'm, overridden by shame or guilt. If I don't do this thing, then I'm being lazy, or whatever the languaging is,
Totally. Well, I mean, like we've had a few people just recently where any major stressor literally takes them out, like almost have to go to the hospital, right? So their body shuts down, they can't function, everybody's worried about them.
Yep.
And then they're worried about what their family thinks of them, if they're going to be there and able to take care of them, even though it's like the stress response and that reaction is what did it. They worry about the other stuff, right? They worry about everybody but themselves in that moment. And it takes a lot of training to undo that. But for what it's worth, I see nurses are the worst in that aspect, or like the caretakers in general. They just go until they break, and then it's like, oh, we've got a lifetime of habits that we've got to undo to make sure you take care of yourself. That is tough for us. But
well, I think that's a common theme that I see with people with chronic pain and even trauma is this kind of dissociation and detachment from our bodies, right? We're not taking care of ourselves in the way that like is really required for us to feel at least better. And so increasing that, again, like that education of why it's so important to like, say like, no, I can't take on like this activity, this work, this meeting, this, that, and the other thing if I don't get to like do my morning PT exercises or whatever it is. Like I need to take care of myself so I can also do the rest. And so that's a big thing that we start to work on too, is like, who's taking care of you? Because your pain is like starting to,
For sure, for sure. Let's talk a little bit about avoidance behavior. Do you want to just go with that?
Yeah, I mean, okay, let's see. And then feel free to interject. So that comes up a lot with trauma. I mean, like avoidance is like one key thing that happens when we go through adversity is we don't want to experience it again. It's deeply painful. So we will avoid all the things that activate like that brain stem and make us feel and think about it. And then same thing with chronic pain, right? Especially like anticipatory anxiety. So I'm going to start, I'm afraid that doing my activities or going to this concert or, doing this thing is going to make me feel worse. So I'm going to stop doing all those things. And that really psychologically, I think, starts to make things a lot worse because now we're starting to isolate. We're not doing things that also are increasing our dopamine, our serotonin, and our feel-good chemicals. And it's also not getting my body any movement, which we need. Like, I think one of the sayings, right, is like motion is lotion. Like our body needs to move. If we're in pain, our body needs to move. And we need to do it in appropriate, healthy ways. But starting to avoid whether it's people, places, or things, it's not like, okay, I've been avoiding, just go do it. Like it's by no means that easy, but it's something to start to pay attention to is what am I avoiding? And then do I have either the professionals or the support system in place to help me start to navigate the emotional content that's coming up associated with those triggers?
Yeah, for sure.
Yeah.
We have one case, she's actually been on this podcast before, used to be so set off all the time, like driving here, put this person into basically a wheelchair.
Yeah.
So they were like, they can walk, they can talk, they can do everything normal, but they're so hyper vigilant based on their experiences that they've had. And it would shut their body down completely. And so, they're able to go and teach dance lessons now and ballet and things like that, but going to the store is still difficult. And they notice, even as they're walking to the car in the driveway before they go to the store, they start to have symptoms, that anticipatory piece, right? And so like as an example, based on the information that I have, I don't have your level of training, but it's like, hey, I've got them in front of me. I know they can't wait for 4 weeks or something. Like, we need to start doing something now. So you tell me if this works or is appropriate in a small sense, but I was like, hey, you know what? Here's the game plan to get you to return to play at the grocery store. Is the first thing you're going to do is you're not going to leave your house and you're going to just do your visualization. Like, what does this store provide for me? I love visualization. It provides nutrition. I get to get all the food, and I love cooking food for my friends and my family. So it fulfills me to be able to go buy the things, check out the things, try new foods, and just go and grab what I need. And I'm thankful and grateful that I have this and I have the ability to do that, right? So that's kind of the first stage of getting over, like, the exposure therapy you call it. It's like, hey, the place we need to go, even though you're afraid of it, we need to find a way for you to not be afraid of it, right? And be thankful for what it provides for you. An example of another person, their jaw was problematic. I think we talked about this before. And I was like, hey, what does the jaw allow you to do? Allows you to tell your husband you love him, allows you to give him a peck on the cheek, make out, whatever, get crazy, sing and create art. And so, like, fall back in love with this jaw of yours, right? Same thing. So we go from the living room, do a little visualization, and then they go sit in the car, they turn it on, they go through one breathing pattern, and they turn it off, they go back inside. So we're trying to shut down the response of just getting in the car. And so then the next thing they do is they go and they just pull up, they sit in the parking lot, and then they leave. And so you don't actually have the physical trigger ever happening of getting in the store. The next thing, you might walk in, grab a cart with your mom, and they take off and they shop. You go back to the car. And it's just these little baby steps. That's
kind of dosing of it.
But that very non-threatening experience to start to overlay the old stuff.
And they still have control.
Yeah, totally. Full
which I
control.
love.
You're never in too deep. You're not jumping in the deep end. You're like putting one foot on that first step. You're not committed to anything, right? But to me, it's basically the same process for working through most things, depending on how intense it is. And I'm talking the day-to-day things, as things that are within my scope of practice. That's everything else gets referred out. But when people, and you probably see people coming from other practitioners, and you're like, what have you been doing? And it's difficult to be like, all right, well, I got to do it. And you'd start to engage a little bit with something that is, you're going to need some extra help with, but I like to try to get the ball rolling, and then we get the referral. I kind of like test the waters to see, hey, is this a problem?
Well, and like level of severity, right?
Exactly.
Like that will work for many. And then for those that don't, that's where, like, okay, who else can step in to support, because it's going to take a team.
Some of those systems are so hyper vigilant that breathing ain't going to help. Like, you got to go do some of this stuff. Like, let's take the top layer off. The acute stuff. Get rid of that. Okay, cool. Now we're starting to see some changes. Now we can get more blood flow to that front part of the brain because it's turning on a little bit. Great. Let's go physically exercise that brain here in this clinic. And then you start to tag team both the physical with what you do. And so that's what I'm looking for. Certainly to have a much better network to send people to. And that's like recognizing on our end of what the best referral for you is the piece. And then we could talk about that behind the scenes. But yeah, that's fantastic. I love. Tell me again the DBR.
Yeah, deep brain reorienting, DBR.
So they can be like, oh, this is totally different than anything I've done before.
It is totally different than anything I think like any of us have done before, which is pretty cool. Yeah, so deep brain reorienting, basically when we're going through adversity, there's a physiological sequence that happens. Our brainstem orients to threat, sight, sound, smell, touch, the look of someone's face, when I pull up to the grocery store, right? There's a cue that the body starts to register, oh, something's going on. What happens to us is we're going through life so fast that in milliseconds, the sequence happens. By the time we catch it, we're in panic. And we're leaving the grocery store, or whatever it is, right? And so deep brain reorienting basically takes the developer has identified that he's figured out the neuroanatomy of it and traced that and basically developed this sequence rather of slowing down the physiological sequence that we go through and slowing it down enough that we can be with the shock and the affect, right? The affect is going to be like the panic, the fear, the grief, the anger, the rage, all of that stuff, the emotional content, the pain that we go through, and slowing it down and processing out the physiological sensations that come up when we're going through that. So for, we orient a threat, i.e. the moment I realize I need to pull into the grocery store, there's something that's activating for that client that when she pulls into the grocery store, it sets off an alarm.
And there might be some that say, dang, I got to go to the grocery store, and they're at home.
Yes.
Just like the act of, hey, can you go to the store and get me this?
That would be enough. Yeah.
Okay.
So it's the moment when we're in session, right? Typically the kind of questioning I'm asking is, what's the moment your body registers something's going on before you have conscious awareness of it? So that's a really great example because it's just in this brief snapshot, right? It's probably actually well before they get to the grocery store. It's probably when mom said, hey, can you go pick up some food? Right?
But like at the moment you pull open the fridge and you're like, there's nothing to eat.
Yes.
Great, I'm going to have to go to the store.
This sequence kicks in. Yeah. And so DBR slows that down and allows us to we drop in using kind of a script. It's called the aware self script. We drop into this place basically in our brainstem that is very grounding and very anchoring. And then that allows us to turn towards this threat in a very stabilizing way. And that's what I really love about deep brain reorienting as compared to other trauma processing therapies that I've used. It's innately very
Instead
very
of recreating the trauma and trying to override it, which is a lot of things.
Because sometimes, to process our trauma can be really traumatizing.
Right.
So ideally we're doing it in a way that's, it's not going to feel awesome, but we want it to feel stable or stabilizing as much as we can, So we turn towards that threat, and then we essentially kind of get in touch with, or what's coming up is those shock sensations. It can be, pain or pressure in or behind the eyes, or a lot of tension or bracing, usually in our neck or shoulders. Think of when your stomach drops, like a hollowing or an emptying, stuff like that. So we actually deepen into, you kind of feel into those sensations that are coming up and be with them. And that's the thing, is we're moving through these events so fast that we're not able to be with the pain that we're in. So it kind of gets stuck in the system. So we turn towards and we deepen into, and now a sequence is happening. And so we're kind of feeling into this physiological sequence. And as we deepen into it, things start to clear and it moves through the sequence. So it moves through the shock, and then it gets in touch with affect. Maybe let's say I'm like, okay, I noticed my stomach dropped, and then I noticed pain behind my eyes, then I noticed tension and bracing, and all of that is cleared. Now I'm noticing my chest is getting tight. Okay, maybe that's some anxiety. Or maybe I noticed my jaw is getting tight. Maybe there's some rage there. Stuff like that, right? Maybe I'm feeling some sadness. So I same thing, feel into those sensations, the pain that's coming through. Feel into it. It will clear. And then what's amazing about the brain, about the body, is it knows how to heal itself. It just needs a little support sometimes. Right. So as we can start to clear that, shifts in perspective start to come in. I don't know, it could be like, oh my God, this memory of this time at the grocery store, this thing, who knows what it is, right? Or like, I can do this. The new perspective isn't always necessarily positive, but it's adaptive. It's more present with what's happening, and it's more intrinsic and intuitive of like, oh, I know those events are over, or like, no, it really was that bad, or, whatever it sounds like.
Yeah. Interesting.
It's changed my practice. I'll say that much. And it's changed the people. I do it a lot with my patient population. I do it essentially with everyone that I'm working with. And the individuals that I had on my caseload prior to using it and then have since used it, I mean, like they love it. Like it's made so many changes for them. And then, the ones that are coming in, they've tried other things. People are a big fan. I think we're all a big fan. And it's new, so it's like they're getting the research done. They're, the training is continuing to develop, but it's pretty revolutionary, I'd say.
That's awesome.
Yeah.
Fantastic. Now, we find a lot of people, at least in our practice, with the types of cases we see, say like POTS and dysautonomia, a lot of people are so dysfunctional that they can't work.
Yeah.
So could you explain maybe some of the physiology behind idle hands as a devil's playground?
Well, I think like what wires together fires together.
Yeah.
Right. So that's a challenge. I feel like that speaks to a lot of things that we've mentioned, right? Is like, I'm in pain and I'm really tired and I'm really fatigued and I have no energy. And so I don't want to do anything. And then the challenge is I'm not doing anything. So now I still have no energy and things are getting worse. So starting to engage in, even if it feels quote unquote passive, but starting to do activities that's going to kind of send some signals and messages to the brain and the nervous system of like, hey, maybe we're going to shake things up a little bit. Maybe I'm still not working, but like maybe I usually just lay in bed all day and just like scroll. Okay, now I'm going to get up and I'm going to get on my couch and I'm going to read a book. or I'm going to like get outside and try to get like a little bit of morning sun, or I'm going to call someone I haven't talked to in a while. I'm going to try and start to implement some shifts and changes. I still don't feel good. I don't want to do any of that, but I want to start to create some daily living changes and some like actionable steps of things are going to start to look a little different. But I would say what I would interject into all of that is to start to use visualization. The brain loves visualization. It does not know what's happening from what we're thinking is happening. And so that's where that like seeing, if I see my body not doing well, it's not doing well.
So if you're saying I'm in pain all the time,
yes,
guess what?
I'm
That's
in
like
pain
verbal
all
visualization,
the time.
right?
Yes.
So what's interesting about that visualization pathway is from what my training is that visualization pathway is actually 40 times more powerful than doing it physically.
Oh, I love that.
So you've heard people like, oh, I learned how to do that by reading a book, or I learned how to do that by visualizing it, by watching. That's why some of the greatest, all they do is watch film. So they see it, they visualize it, and then they go practice. So they already know what they're doing before they step foot on the court or the field or the golf course or whatever. And so visualization can be extremely powerful.
So powerful.
And which is why we're always asking, what's the first thing you think about? And when you wake up, when this happens, what is going through your head? Not like what you're feeling per se, but what is that sequence of processing is, oh, well, this isn't going to go well, right? So people, when they first come in and they tell me, like I'm asking questions, they're like, no, like you explained it all. Like I finally have hope. I know that person's going to do well because that train of thought is way more conducive to healing than, well, we can give it a try.
Yeah.
It's like, okay, so you're already half in, half out.
Yep, they're bracing that
like,
it's not going to happen.
We can certainly try to convince you, and we have to show you and maybe earn the trust because you've had PTSD from going to doctors your whole life.
Fully, yeah.
And like
There's
that's a whole other thing.
Yeah, it is.
So like if that's ever the case, my joke is, well, it's a good thing I'm not a real doctor. It's just a chiropractor, right?
Here we go.
And so it should make them laugh. And it's like, hey, it's just, I think our clinic is certainly like no other clinic you're going to go to.
Yep.
And hopefully it's apparent once they're here. So based on, by the way, this has been fantastic because we do similar work just in, I'm not allowed to do certain things and you do all the things I'm not allowed to do, which is great. So what would you say, what's like a very obvious referral for someone out there that's like, I've gone to therapy for years. Like what are they going to need to have really failed? Obviously, we'd love to see them first.
Sure.
But what is a pretty typical sequence? Somebody fails. I've tried hypnotherapy. I've tried counseling. I've tried EMDR. I've done nothing about it, right? Like what, at what point do they need to come see you?
Probably all of those things, right? I mean, like typically, oftentimes it's like, I've tried therapy or I haven't. Let's say for the ones that have, they've often tried talk therapy, right? Or which is very top down, right? So prefrontal cortex, we're gonna talk about the narrative, one of just these are the things that I've been through, which is going to be re-traumatizing. Yeah. Or we've been skill building, which is with CBT or DBT or whatever, which is great. However, we still have the stuff running in the back end part of the brain. So have we used the right therapies or have we been engaged with the right like clinician or therapist utilizing the therapies that are going to be most effective for what that person is struggling with? And I think most people haven't. I think that, there's this kind of blindness that we all get of like, well, if I've seen one, I've seen them all. And that is just not true.
Right. I fully agree with that.
Yeah.
So people who may have, I'm going to throw out the way I kind of am processing what you're saying and the conversations we've had before is if someone is seeing, let's say you love your therapist, and you'll hear this all the time, right? Oh, I love my therapist. Why would I go to another one? Well, because it's a different application because you've been going to this person for 5 years and you're still at 40% function.
For sure.
Like, you got to change something. Well, they got me to 40% from 10%. Great. They can't get you any farther. Like, it's okay to go work with someone else when it's time. Like, it breaks my heart to have to refer someone else, one of my patients to someone else because it means I wasn't able to accomplish the ultimate goal, which was get you feeling great. But it's nice to have referral partners who's like, this is exactly where you need to go. That's exactly where you need to go. Or, hey, we've got to just unravel this whole onion here. You got 2 or 3 people you need to go see. We were able to accomplish this. Now it's time for you to spread your wings and go dive into these because I think it's like now you're ready.
Well, and I think that's the key piece. And I think you and I have talked about that before. It's like there's just so many layers to this. So it's not like, all the work that someone's done is like for nothing.
Right.
It got us to this stage to be able to kind of have more of a spotlight on this greater issue. And for this other issue, we need this specific specialty to treat this thing.
Right.
And then like once we get that stabilized to a place that you want to be, you can either decide, do I want to go back to the clinician that I had, or do I want to continue in this, or am I done for now?
Right. Right. And
Yeah.
we talk about it, say like pillars of health, right? So there'll be your neurological, your abdominal, like basically you look at brain, body, and biochemistry, right? All the physical people are going to take care of the body, which we can, but generally we focus on the neurology. When you talk about neurology, you're obviously talking about psychology. And so like those are one and the same to me. So it makes it easy to either get a referral from you, know that that's already been taken care of, and then we just got to strengthen the brain, the physical side of it, and the integration. Or we strengthen the brain to a level where then they can handle the trauma work. That's kind of like that. I feel is a really good 1-2-2-1 punch. However it ends up, if it's like it's always worked. There's really been almost nobody that it hasn't worked in that way. Certainly anybody with like anxiety or any of the really deep rooted stuff or any trauma, it's like it seems to be that there's that strengthening component, and then you can handle all the trauma. And that would be our role in like a patient that's on their way to you. Where I would love to be able to, because I get a lot of joy out of watching that change with people. It's just I can't do it.
Yeah, same. I know. I wish I could.
So, anywho, what else? Is there anything you want to leave these guys with? Certainly, we're going to tell them how to get in contact with you. But any last words that you'd like to share?
Yeah, I mean, so I think if we're speaking like to the pain population specifically, is see how we can start to build a different relationship with our body and our mind. Is starting to trust that like the body knows how to heal itself. We just need to have like the supportive therapies that can get us there. And it could be seeing clinicians. It can also be doing like a lot of like at-home stuff and starting to work. Like we kind of want the nervous system, the brain, the body, the mind, all of it to be friends. And oftentimes we're kind of not working in that fashion. So how can I start to build a better relationship with myself, enhancing myself, sense of self, and working with the relationship that I have with my body? Oftentimes there's so much shame, hatred, all kinds of stuff. So that's going to get us further from the goal. So what are, just a couple of things that I can do, or one small thing I can do each day that's like, hey, I'm starting to like just treat my body like a little bit better. And that literally can just be like, I'm going to change the style of thinking. It can be like, oh, like I deserve to rest. Or I deserve to do my like at-home exercises because like I am a human and I deserve to feel good, whatever it is.
And it's funny too on the word that you use. Like a lot of people say, "Oh, I had a lazy day," and I'm like, "Well, was it lazy meaning like you didn't accomplish the things you were supposed to, or was it like actually productive because you've been going a mile a minute for the last 2 months straight?" Right. It's like the word can completely change the meaning, right? And so we try to talk a little bit about that stuff. It's like, and it's, if they don't have the ability to go deep and it's like they need you, but you can't, you're like, they're too screwed up right now. Or they're probably not, but, if somebody's just their tolerance is so low, like, hey, use this word, not that word.
We start there.
And so
that's a big one that comes up. I'm sure you and I can go down a rabbit hole another time of the, if I'm resting, I'm being lazy, and we don't see it as rest. We see it as like I'm being lazy or I'm doing nothing.
Which the guilt and all that comes out. Which causes the next sequence of events, right? Whether it's the pathway or the chemical or both. I mean, they both fire at the same time, right? So it's just psychology is just so fascinating to me. So So just fun fact, I took advanced psychology in high school.
Love it.
And it was awesome. I didn't pursue it. I wish I did.
I mean, you've got quite a bit of good training.
So, okay. All right. So Beth here is going to tell you exactly how to get in contact with her and to stalk her on social media and things like that, right? So go ahead and tell these guys.
Sure. So the best way to get in contact with me is through my website, evolvephx.com. And then I have a booking link right in the top right corner. Social media, evolve therapy _PHX. And I have a Psychology Today. A lot of people looking for clinicians look on there too. That's
Okay.
also a good resource. So if you're looking for a therapist, Psychology Today is also a great resource.
Is that just another website?
It's a website that houses like all types of clinicians.
Oh, okay.
And then you can put in like your zip code if you're looking for insurance or private
Just like
pay.
a directory of stuff.
Yes.
Okay, cool.
So that's a good one too.
Awesome.
Yeah.
What's your phone number?
480-269-2238.
Perfect. If somebody's looking to get in right away,
Yes.
are you on any kind of wait list right now?
Just about a couple weeks. Like
Okay.
I'm usually booked out a couple weeks. So I would, if someone called me today, I probably could get them on my schedule in about 2 weeks.
Okay,
Yeah.
awesome.
Yeah.
Fantastic. Well, there you have it, guys, from the mouth of the master. If you guys have any questions, you can reach out to me. I can get you in contact with her, or just reach out straight to her. That would be a better resource.
That sounds great.
You guys, thank you so much for sitting through this episode of the NeuroRESET podcast. We want to thank Elizabeth again, or Beth, at Evolve Therapy, and we will see you next time.